Good morning and welcome to the Caregiver Teleconnection. My name is Glenda Rogers and I'm going to be your facilitator for today's session. We have with us Dr. Heather Veeder from Vitas Healthcare, and she's going to be talking about hospice care. But before we get started with her presentation, I want to ask Candace Ramos with Vitas to tell us a little bit about Vitas today.
Thank you, Glenda. At Vitas, we care for hospice patients wherever they call home with an interdisciplinary team comprising of a nurse, physician, aide, social worker, and chaplain. Our teams design personalized care plans to ensure comfort, dignity, and quality of life. Vitas offers several key services that support patients and their families as they provide hospice care at home. Our telecare clinicians are available via phone 24/7, 365 to answer questions and dispatch someone to the bedside if necessary. Medical equipment and medications are delivered to the home as well, and respite care provides up to 5 days of Medicare certified inpatient care for hospice patients so that family members can take a break from their caregiving duties. Vitas Healthcare currently provides hospice care in 14 states, California, Florida, and Washington, D.C., to name a few. In the great state of Texas, where I am, we have locations in San Antonio, Austin, Houston, Dallas, and Fort Worth. For more information, call Vitas Healthcare at 1-800-723-3233 or visit www.vitas.com for information and support from the nation's leading provider of end-of-life care. I hope that you enjoy Dr. Veeder's discussion.
Thank you, Candace, very much. Always good to see you. So before Dr. Veeder gets started, let me tell you just a little bit about her. Heather Veeder has been with Vitas Healthcare since 2015. She joined Vitas as medical director in San Antonio, Texas, and became regional medical director in 2019. Her mission is to prevent and alleviate suffering, meeting patients and their families where they are in their journey through advanced illness. Dr. Veeder is a board certified in hospice and palliative medicine as well as family medicine. She currently serves on the board of directors for the Texas-New Mexico Hospice Organization and previously served on the board of directors for Abode Contemplative Care for the Dying in San Antonio. She is also an active member of the American Academy of Hospice and Palliative Medicine, American Academy of Family Physicians, Texas Academy of Family Physicians, and the Gold Humanism Society. She also serves as an adjunct faculty for the University of Texas Health in San Antonio, working with fellows and other learners. Working with these organizations allows her to care for patients and their families directly and support hospices, their employees, learners in the medical field, and others in the community. Welcome, Heather.
Thank you, Glenda.
Before you get started, would you tell everyone, because I found this to be interesting when I talked to presenters, what led you into hospice work? I'm sure that wasn't what you thought in the very beginning.
No, when I went to medical school, I was going to be primary care, family medicine. I probably would have ended up in something like WellMed. But then when I saw people being treated past where it was beneficial, and I saw people suffering because they thought it was the only way to move forward, and being in some ICUs, and then seeing the opposite when my grandmother needed hospice and she got to stay in her home and didn't go back and forth to the hospital. We had wonderful support from family members, but from the hospice that took care of her, and really seeing that there was another option that could help people avoid pain and suffering. That was what I needed to do. I needed to go into hospice. And that was actually the reason I moved to San Antonio, was to do my fellowship so that I could do this.
Excellent. Thank you for telling us about your journey. So please go ahead and do your presentation. We're interested to hear the information.
Thank you. So today I'm going to talk about some common hospice myths that we see, that we hear different, people saying these things or similar things. And I'm hoping to dispel some of those myths and provide a more accurate picture of what things really mean when we talk about hospice. So myth number one, hospice means my loved one is dying. So partly that is true, but it doesn't mean that my loved one is necessarily dying right now. So what does it mean when somebody gets referred to hospice? It means that their healthcare provider thinks that their patient may be terminally ill. If somebody gets admitted to hospice, it means that the hospice physician agrees that the patient's terminally ill. So what is terminally ill, right? That depends on what country you live in, where you are. In the United States, it means that two physicians agree that someone is more likely than not going to die within the next 6 months. Right? So really hospice is designed so that we can support patients and their families and their loved ones, not just at that very last, few hours or days of life, but those months leading up to it, so that there's always somebody available to help when things change, when something happens that is, distressing, or we don't understand why it's happening. We can be there to walk through that with you. So, and right, we all know hospice can be a bad word, right? The H word is something that we're well aware of. And I tell people, hospice is something that nobody wants to have. But once you need it, you're really glad you have it. And I think so much of our medical community and our community in general, right? We're anti-death. And it's hard to be anti something that happens to everybody. And it doesn't make it easy, but it also is something that is natural and we all have to go through at some point. I feel like if we could take away the fact that hospice is a bad word, right, it would change a lot of things. But when people hear hospice, right, a lot of times it shuts down conversation with the patient or their loved ones. And we get this negative cycle, right? Someone says, well, maybe we should consider hospice, and people, nope, we're not going to do it. And then by the time a patient enrolls in hospice, it's so late in the disease process that it becomes the reality that my loved one is dying right now. But it's not because that's what hospice is. It's because we are, as a society, I think, so scared of addressing these issues until they're in front of us, and we absolutely have to. So I think as a society, we do a disservice to so many people by not encouraging them to reach out and utilize all of the services that we can provide. So our myth number 2 is that hospice is a place that sick people go and they never come back. Well, my first thought in that is hospice is not a place, right? It is a service that we provide to someone who's eligible for hospice. It's also, again, for their family, their loved ones. It is provided by our team, right? Our interdisciplinary team, clinical team, psychosocial team, therapy, sometimes massage, sometimes music, right? A lot of different specialties can go into supporting someone in hospice. And we provide it wherever somebody calls home, whether that's in their home, their apartment, wherever they are, they're a nursing home, an assisted living. And of course, we do have inpatient units. In Texas specifically, all of our programs have an inpatient unit, so that if somebody needs even more intense care, more acute symptom management, we can provide it there too. So wherever somebody is for home, we can meet them there. And then the comment, the worry about sick people go there and never come back. Sometimes people do get better, right? Sometimes we were wrong when we thought somebody was terminally ill. If somebody does get better and we don't think that that person is terminally ill anymore, we can discharge someone for what we call extended prognosis. And I think, this is one of the best discharges to be able to do, right? Because that means, somebody has more time left, right? And we coordinate with the primary care and other specialists if needed, so that we are not going to just say, okay, you're discharged. No, we're gonna call up your physician, and we're gonna coordinate with their office as to how we're gonna transition that care, right? We aren't taking any hospital beds or equipment out of the house until, if somebody needs some, right, until home health can come in and replace those. So we're never going to dump somebody out on the street or take our equipment out without others in place. And our myth number 3, hospice means giving up. And I think this is one that I really see my fellow physicians struggling with. People are worried that if we tell our patients, this chemotherapy isn't really, it's really not going to help. It's not going to cure, or it might give you another couple weeks, but you might feel horrible during those weeks because of the side effects. Right? They're afraid to share this, and they're afraid to say, I think it's time for hospice, because if they say that, then what they're saying is, I don't have anything else that I can treat you with that's going to make this better. When really, when we have that conversation, it's actually allowing someone to have realistic hope, right? If we keep offering treatments, it's going to be, our patients are going to do that with the understanding of these treatments are going to somehow make things better, right? Whether it's longer or, allowing people to do other things. It isn't, I'm not saying that it's dishonest, but it's not completely honest if we aren't allowing our patients and their families to make decisions based on what is really going on. So when someone does get referred to hospice, when we bring them on, it might be a different hope than it was before, but it allows people to focus on what is important in the time that they do have left, right? If they need to forgive someone or ask for forgiveness, if they need to reconnect with somebody, if they have, and they're able to, one less trip that they need to take, or maybe financially, right? I see a lot of patients who they're so worried about how their husband or their wife is going to be okay financially. It's a big relief if we're able to come alongside them and help, right? Even things like filling out advanced directives, right? Maybe getting a will done, maybe making sure that helping make sure all of the bank accounts are in both people's name, right? That we have things in place that even after I'm gone, I know that my wife is going to be okay. And we also don't coerce people into hospice, right? This is something that the patient or their decision maker, right? They have to opt for it. They have to enroll in it. So our responsibility is to talk about what we can provide, how we can help support, right? And then once they've done that, right, then they can focus on the quality of life. They can focus on home and family and what's important to them. And I think all of that is what I'm saying here is this next bullet of when people with advanced illness, either they're no longer willing or they're not able or they aren't offered curative medical treatments, then we can work to provide that support, whether it be medical, spiritual, or emotional. And again, not just for the patients, but for the family members too. And what we see in multiple studies is that the families and the loved ones often wish they had not only known about hospice sooner, but they had understood the support that it can provide. So going on to myth number 4, that hospice is nothing more than hand holding in the end. So hand holding is really important, right? It's not the only thing, but it is an important thing. I will give an example that I just heard yesterday from one of the nurses that I work with, and that we had a patient that was transferred into one of our inpatient units. And he didn't have anyone with him at the time that he got transferred. So we had the nurses who were transporting, and then this nurse was there. And he had his hand out and he was just looking for someone to hold his hand. That was what he needed to feel safe. So she spent, I don't know, 15 minutes, 20 minutes, just holding his hand, right? Making sure that he had somebody with him to feel safe. And that was probably the best medication, the best intervention he could have had at that time. So if what somebody needs is hand holding, that's what they need. That's what they get. That being said, hospice is a lot more than hand holding, right? Again, supporting the person and their family, their loved ones. And we're also providing medical interventions. So the medications that make somebody feel better, we're going to provide. And there are times when somebody needs something that is more advanced. Maybe they need IV medicine. If it's going to help somebody feel better, if it's the right thing to do for that patient, we can provide it. We also provide skilled nursing, right? We have RNs that are visiting our patients at least once a week. We have LPNs that are also providing support. We provide caregiver training. So not only, right, because when we aren't there, of course, it's the caregiver, the family members taking care of their loved ones. We're helping with that. We're training them. This is a safe way to transfer your father, or this is how to look for pain in your mom's face, right? She can't tell you when she's in pain, but when she's furrowing her brow, right? That's an indicator of pain. And then this is how you can give this medicine, right? And then we're also available 24/7 if someone's still unsure or if they need more help. Our home health aides are certified aides. We make sure that all of them are certified so that they are providing the best care that they can. We have social work support, chaplains or spiritual counselors to provide spiritual and emotional support. And then we have, I guess, what we would call our ancillary services. So for the patients that would benefit, we can have a therapist, a physical therapist, occupational therapist, speech therapist. Now, granted, those aren't things that most of our patients need, but if it would help them, if it would be beneficial, right, we work with them. We have respiratory therapy, massage therapy, pet therapy. My dog was a pet pal for a couple of years, or a paw pal for a couple of years. And we got to visit patients and their families in the inpatient unit, in some of the nursing homes. And it was great to see the smiles on people's faces. Or when we were going in to volunteer, and my dog Katie was with me, of course. And one of our patients had just died, and the family was milling about in the hall, and they saw Katie, and they swarmed her, and they were petting her and loving on her. And right, that they needed that, right? I didn't know they needed it before I got there, and they didn't know they needed it, but she did a great job by just being a dog. So we have a number of things we can do, and not just dogs or volunteers. We have human volunteers as well who can do similar things. And then one of the other things that I think is really important is that after our patient dies, we provide bereavement support where we are doing outreach for at least 13 months. Past that, we also have bereavement support. And frankly, even if you have had someone close to you die, whether they were on hospice, whether they were on VITAS, you can call and we will help get you connected to a bereavement support group, or connect you with a counselor, right? You don't even have to have been affiliated with VITAS in the past. We think it's such an important thing to be able to provide that we will provide that. But we don't want to forget about people just because they aren't on service with us anymore. And then the other thing with the services that we provide, right? So the team makes regular scheduled visits to our patients, right? So often, it's scheduled once a week, twice a week for the nurse to go out there. Depends on our patient needs. And then our chaplain and social worker, right? They'll be out again on a regular basis, depending on the patient and family. But we have nurses available 24/7 to come out for a visit if something happens. If something happens in the middle of the night, right, you can call and you can get in touch with a nurse 24/7, and they may talk to you over the phone and help with something that might be urgent, but doesn't need a nurse to come out. They can also do a telehealth visit where they're on their computer, and you can do a face-to-face telehealth visit. And then also if it's needed, we can also dispatch one of the local nurses from the program. So we have somebody available. We also have physicians and nurse practitioners that will be visiting for recertification purposes. And then if there are, again, increased needs or we need physician or nurse practitioner, we can do visits as well. So I hope you're getting the point that it's not just hand holding, even though hand holding is very important. But there's a lot more going on in the background to support your loved one and you. So our myth number 5 of 7, I believe, yep, is that hospice is expensive. So if your loved one is with WellMed, when they come on to hospice, it actually flips to Medicare, to traditional Medicare, and that covers hospice care, right? No deductibles, no co-payments. The only, anything that is related to hospice is going to be covered. In most states, Medicaid provides hospice coverage, but it may depend, of course, on what somebody is, what plan they're selecting. And then also almost all private insurance plans have a hospice benefit as well. Way too many differences in theirs to talk about that. But if you're in a Medicare Advantage plan, it's going to be Medicare Part A, and hospice is not going to require deductible. It's not going to, there will be no out-of-pocket costs for any of the treatments related to hospice. So the team visits our medications. Medications will be delivered to the house. We generally deliver medications every 2 weeks. We also provide the home equipment, medical equipment, supplies. So again, anything that is related to the hospice illness, to why someone is terminally ill. So hopefully that alleviates some worries. Number 6, and I have heard this a lot. Hospice will stop all medications and treatments. So that is wholly untrue. Right? So our goal is that we are focusing on that optimal quality of life, right? We're relieving symptoms, supporting the caregivers, meeting the needs of our patients on their terms, right? We want to work with our patients and their families, right? So what is really important to them and what can we do to help them meet those goals? Each patient has an individualized care plan. So again, to that, so if we want to have that care plan to manage all of the symptoms, and when I say symptoms, I don't just mean physical symptoms because I'm the doctor, but I'm also talking about the emotional support, the social support, the financial, discussions. So we're doing this so that we're making sure we're meeting all of their needs as best we can. And then when we do evaluate medications or interventions, it's based on each patient, again, in the context of their individual goals. So what does that mean? That means that if a medication is no longer helpful or it might be harmful, right? I'm gonna recommend that somebody not take it anymore. Things like our statins, our cholesterol medications are often, they're medications that often cause, muscle pain for people, but they're also medications that are really made to help people down the road, right? 10 years from now, that cholesterol medicine would be really helpful. accept that when someone's enrolled in hospice, that 10-year mark isn't what matters right now, right? What matters is that next amount of time that they have left. So why take a pill if we don't need it? If we're worried about making sure somebody eats okay, the fewer pills I put in their stomach, right, the more food they can put in instead. Or if somebody has been on a blood thinner for a long time, and they're starting to fall, right, then I'm worried that that fall and being on that blood thinner, if they have a fall and they start to bleed, I don't have a way to stop it. So I would rather hold that, because the risk of that fall is more than what the benefit of that medicine is. So it is never no, right? It is looking at each medication in relation to that patient's situation. And I also want to say, I say non-drug therapies are also really helpful in managing symptoms, enhancing quality of life. So before I was in hospice, right, as a family medicine doc, I always leaned toward kind of that minimalism of, if I don't need to give a medication, I would rather not. Right. So if somebody is having trouble breathing and what they need is airflow, right, then let me turn on a fan. But if they need oxygen, of course, right, we will give oxygen. But I don't want to give medications unless I think they're going to help what's going on. Any medication that I give could have a side effect. So why not try things that don't have side effects first? And then the last myth that I'm going to talk about is the withholding of nutrition or hydration. I think this one is really loaded emotionally and ethically, right? Because we see so many people struggle with either their loved one isn't eating as much, or okay, well, you know what, they're not taking anything in, we need to give them fluids. And sometimes the things that seem like the best answer, the right answer, are things that could actually be harmful. So we will not refuse nutrition or hydration for a patient, but also we will not force nutrition or hydration. If somebody is getting nearer to death, they usually lose their sense of hunger and thirst, right? Think about when you've been really sick and you're just like, I just want to sleep. I'm not hungry, right? Don't give me any food. I just need to sleep. We, as people get nearer to death, appetites decrease, intake decreases, and it's really a natural part of the process. And when we interfere with that process, it can make somebody feel worse. So specifically, artificial nutrition and hydration. When someone is imminent or actively dying or getting close to that, adding more fluids can actually do the opposite of what we want them to do, right? We think if we give somebody fluids, it's going to help wake them up, or it's going to stop them from starving. I can tell you that people aren't starving to death in this situation. Like they are not eating because they're not hungry, right? Because the body doesn't need that nutrition anymore. But one of the things that happens in the body as someone is getting closer to death is when there's any extra fluid in the blood vessels, it'll leak out. And that fluid has to go somewhere. So we will see that fluid, sometimes it builds up in the heart. Sometimes it builds up in the lungs. Sometimes it'll leak out of blood vessels into the surrounding tissues and we'll get swelling or edema. And those are all things that if those happen, that can cause, the dying process to become suffering, right? And we know in my intro, my job, my mission is to prevent and alleviate suffering. So if I can prevent that by saying, we don't need to add extra fluids, right? We don't need to force feed anyone, then I want to do that, right? It seems counterintuitive, but a lot of times what we're doing is helping someone be more comfortable by listening to their cues, by watching that. Now, that doesn't mean that we don't offer small bites, sips, that we don't moisten somebody's mouth, right? Those are things that are going to feel good to somebody, right? If they want to taste of something, but if we offer it and they don't want it, we know that we've done the right thing by offering, and they're telling us by word or by not taking it in that they don't want it. And I also wanted to talk briefly about so PEG tubes or feeding tubes, right? We have a number of types of feeding tubes. NG is, through the nose, and then there are a couple that go in through the stomach. PEG tube or a J tube, you may have heard. So the American Geriatric Society, the AAHPM, which that's the Hospice and Palliative Society that I'm part of, family medicine, GI medicine, and some others, they recommend against doing PEG tube feeding for patients with advanced dementia. Right? And they've specifically put these statements out because those feeding tubes can cause distress, right? We can have complications, and they don't help people live longer. They don't prevent aspiration. So, right, a lot of times feeding tubes are put in because somebody can't swallow without breathing the food or the liquid into their lungs. Well, when people have advanced dementia, putting that PEG tube in, they can still aspirate because sometimes the tube feeds can actually go up into the lungs from the stomach. So, right, it seems like a great answer, but it isn't. Like, people might gain a little weight, but it's not weight that helps them be healthier. So what all of these societies recommend, and what I recommend, is what's called oral assistive feeding. And that is it's careful, slow, like spoon feeding, where we are offering food to someone, small bites. They're usually sitting up in a certain way to help prevent aspiration. But that's actually the safest way to feed someone with advanced dementia, and a lot less worry than having a PEG tube, which is now making it medicalized, right? So it isn't easy, right? It takes time, it takes patience, but it also allows someone to have that pleasure of eating. And someone with advanced dementia, I don't know how much pleasure they get in their life, but if they like to eat and they like that food, that is something that we can do for them. So I hope that this was helpful. I hope it gave you some information that you can use or share with others. And I'm going to stop sharing, see if anybody has questions or comments.
All right, the chat box is open. I see a couple of people have phoned in. If you'd like to make a comment or ask a question, you can press *6 on your telephone. It will unmute it. and I will call on you by your area code. Others, I will just call out your name. The chat box is open. You can put questions there as well, and we will read them aloud so that our people on telephones can hear what is being asked. And Dr. Veeder will try and answer your questions. So please go right ahead. We'd love for you to join in the conversation, and the information was really informative. Some things that I had not heard over the years either, Dr. Veeder. So thank you so much for covering that. Let's see. Catherine, you have a question.
Hi, Glenda. I don't have a question, but I just have a comment I'd like to make. I'm on this call not for my parents because they have both passed, but for my aunties. One's 83 and one's 87. But I wanted to make a comment about when my mother was sick. My mother did have dementia, and her PCP suggested to my family, my father and my 3 sisters, that she be put into hospice. And one of my sisters was just not ready for that. She just refused. And what helped her decide to go ahead and put her into hospice was talking to a hospice doctor.
Mhm.
The doctor came in and talked to us as a family and explained what the process was. My sister thought right away, she just went to, okay, well, you go into hospice because you're going to die or you're giving up. All the things that you talked about, doctor. And the doctor explained everything to us in detail, and he was very, very thorough. And one of the things that he did say that I remember to this day was, if you're holding on to a loved one because you're holding on for yourself, you're not ready to let them go, it's being selfish because that person is suffering. And you need to think about that. You need to think about that person, how that person is suffering, and let them go. And that was what I think helped my sister to make that decision. And after that visit with the doctor, she decided, to let my mother go into hospice. And another thing that she said was, when she goes into hospice, they're going to put her on morphine, and then she's going to be gone right away. And that's exactly what happened. But being on morphine, she was comfortable. She wasn't suffering anymore. And, it helped her, to pass, peacefully, and stuff. So I think the doctor made a big difference in our decision. And I was really grateful that her PCP suggested that.
Yeah. Yeah. And that's hard, right? And those are hard conversations to have.
Yes.
Right? I don't think I want to hear that I'm being selfish because I love my mom, right? But it's not selfish to want her.
No, it's not. But you can
Mhm.
understand that was difficult, and that was difficult to hear. And I mean, it just made an impact.
Yeah. Yeah. Oh, thank you for sharing that.
Sure.
Thanks, Catherine. Appreciate that.
Thank you.
Joanne had a question. At what stage do those with dementia qualify for hospice? What if they are not yet on Medicare payments? It was phrased a little different, but
So for patients with dementia, so it varies on the type of dementia, but really it's, so if someone has Alzheimer's, they generally need to have a fast of 7A or greater. So they're really losing their ability to communicate is the big thing there. And they're also becoming really unable to ambulate. Now, if somebody has a different kind of dementia, or it's a mixed dementia, if somebody is frail, if they aren't, doing very well, and they are now sedentary, really sedentary because they're ill and they are sitting in a chair or in bed more than half of the time, I would say that's the time we need to evaluate for hospice, because if they aren't eligible for hospice yet, they're going to be eligible really soon, most likely. Right. It's tough because we have our guidelines from CMS, right? But it's different for each person. So that's generally what we're looking at, though.
Did that answer your question, Joanne?
And then the
That
insurance.
helps. I work with caregivers and I refer, my motto is, as soon as you qualify, get on hospice. That's what I tell them. As soon as I qualify, I'm getting on hospice, because
Yeah.
I've used it for since the 80s. But yeah, I'm in Mississippi actually, so I'm not sure if there's any state regs, but that's my experience too, that sometimes they qualify, but I didn't realize that it was a different diagnosis that might help.
Yeah. Because I think in the like the LCD guidelines that we have are, I would say that they're outdated right now. They aren't as evidence-based as the evidence we have now. So
Mhm.
Alzheimer's people are usually much less functional, but that's if someone had Alzheimer's and nothing else. And almost none of our patients have only Alzheimer's disease. Now, you also asked about if they aren't on Medicare yet.
Yeah, just the payments for, I've seen some early onset, like 50-year-olds that lost their job, didn't have medical insurance.
Oh, okay. My hope would be Medicaid. I do not know Medicaid in Mississippi, but I think all of the states have a hospice provision in Medicaid.
Okay.
It'd be that, or they'd be started on disability and then
Yeah,
become
eventually.
old, but I don't have a good answer for that one.
I know the tradition is they don't turn anyone away if they can't pay, but I don't know if that's.
I think it
That's
depends on
awesome.
the hospice and where they are financially, right? If you can absorb that, then yes.
Yeah.
But yeah, I think the safer route maybe is if there's somebody able to help get them Medicaid.
Yeah. Mhm.
Thank
Thanks.
you,
This
Joanne.
was
Appreciate that.
helpful. Yeah, very helpful.
Thank you.
Thank you. That brings to mind, Heather, people can go in and out of hospice. If they improve, then they can come off of hospice and come back later. Is that correct?
Yes. And that's right. Like, I said before, I like being able to discharge people for extended prognosis, right? It's we'll tell people they're graduating sometimes. So we've seen some of that, especially throughout COVID, where people have had, they were already sick and they got COVID, and they were just, there was no doubt that this person was going to die soon. And a few of them didn't, right? It took a while, but they recovered, and then they recovered to the point that we said, well, I don't think they're dying now. So when they get to that point, when they are to the point where they're terminally ill, we will gladly welcome them back and be happy for them that they had more time with their loved ones.
And so, thank you for that. That's what I assumed had happened. If someone, I'm talking about a family now that maybe the physician has not referred them to hospice, but they've been given a diagnosis that indicates their loved one is terminally ill, they can call you directly or no?
Yes, they can. And if we get we'll call that a self-referral.
Yeah.
We can go out and meet with the patient and family. And then our next step is reaching out to the physician to see if they are able to give us a referral.
Mhm.
We don't always, the vast majority of people give us a referral, and it's an appropriate thing. There have been instances where we haven't been able to get in touch with the physician for one reason or another. And then we determine a way for someone to refer. But if somebody needs hospice, I want them to get hospice.
Right,
Um,
right.
I'm
And that's-
on with Joanne. As soon as I'm eligible, I'm on.
That was the reason for my question, because as soon as a family gets that indication, like Joanne said, they need to contact hospice. And maybe you may not qualify at that moment, but like you said, Heather, eventually that may be a need that they have. I'm asking questions on behalf of all of you, so I'm not trying to not entertain your questions. I'd love for you to speak up or write something in the chat box. In the meantime, I have some other questions that perhaps you're thinking about or that may be informative to you. I know that one question I've heard over time on the Caregiver Teleconnection, Heather, is can you continue to see your personal care physician? How are they involved in the process?
So that is between the patient and their physician. So if they want their physician, whether it's primary care or maybe one of their specialists, if they choose that physician as their attending or a nurse practitioner, a nurse practitioner cannot certify terminal illness, but they can manage patients. They can still be there attending. And they can be as involved or not involved as they want or as is appropriate. Some want to be the attending and they're getting their regular updates. Others are still seeing their patients. Some of them, if people are still able to get to the office, they might see them. Some of them are doing home visits. And then we have some that actively follow their patients where when our nurse is out seeing the patient, that they'll call them to update and for orders. So it runs the gamut, but they definitely have the opportunity to do that if they want.
Well, that's great. That's great. I was unaware of what the answer would be to that. And you spoke about this, but I still hear it over and over. And so I want to bring it up one more time. When you enter hospice care, there is not someone from hospice that is with you 24/7. They are available 24/7, but not with you 24/7. A lot of people I've heard have the concept that once you enter hospice care, then somebody's going to be there. Many people are working during this difficult time, and they have to figure out how to support the person that is dying while they're away. So do you have any comments on that?
So my first comment is I know that can be a challenge, right? That can really be a challenge for caregivers. And right, we are there to support, but we are not there to provide that 24/7 care. I think a lot of that comes from the misconceptions around continuous care or intensive comfort care, where somebody may be in the home 24/7. We may have a nurse or a home health aide. But that's usually when we have continuous care or the crisis care. We have at least 8 hours in the home because we are actively managing symptoms, right? But it's not to be, it's not really meant to be that what am I thinking of? Like residential type care that you would expect from a nursing home.
Right.
But, and if that is an issue too, again, that's working with our social workers to help figure out an answer. We can help with, find nursing home placement. We can, refer people to caregiver companies. So No, I'd say none of it's easy, but we can definitely help.
Well, yes, and that's a good reminder about the social workers that you have on staff, because they are just full of all kinds of resources and
Mhm.
can connect. So that's good. And
Yeah.
my last comment is about the feeding tubes. I am so pleased to see that, because over time we hear of so many people with advanced Alzheimer's, advanced dementia, and the family, because they're trying to hold on,
Mhm.
request that. And in my mind, all you're doing is prolonging suffering. And so I'm so glad that statement has come out and that people are viewing that in a different way.
Well, thank you. Yeah, those are in Choosing Wisely. I think it's choosingwisely.org is a like repository that you can go to that shows what the different medical societies, they have these, each of them have, I think it's 5, or so statements of these are things that we think everybody should know from our specialty.
Oh. M. Foreman says, I may have missed this information. Is there certain durable medical equipment a patient can't receive under hospice? Cannot.
Not that I'm aware of. I'm not sure if there's something specific, but what I would say is if somebody needs equipment, we provide that. So the hospital bed, the bedside commode, if somebody needs a Hoyer, right? Well, we have a Hoyer there, wheelchair, jerry chairs, things like that. Yeah, I mean, if it's appropriate for that patient, right? Of course, then we provide it.
And I would say to M. Foreman, is there something specific, a specific equipment that you have heard or know about that was not allowed? Maybe that would help us answer that question a little better. I want to, well, it is noon here in Texas, but I don't want to cut us off if we have other questions, but I would like to tell you that you will be receiving a follow-up email if you register for today's call. In that email, you will see that there is our request for you to give us feedback on how the call went in your opinion. I would encourage you, if you have heard a topic or you have heard a speaker in the past that you would like us to present here on the Caregiver Teleconnection, we'd love to hear from you on that. So yes, she said, or he said, I'm sorry, there is a certain wheelchair that they were not provided, I assume.
Okay.
So is it motorized perhaps or something like that?
Yeah, motorized would not be something I think that a hospice would be providing. I mean, I know how challenging that is to get in the non-hospice world. It may be something that they weren't able to obtain, right, through their DME. I mean, it's probably something specific enough that I can't answer, but I mean, I can answer offline.
Yeah. It was some kind of a tilt wheelchair.
A Broda chair. Yeah. It would probably depend on the specific hospice. We'd probably have to get into weeds on that.
Yeah. Be worth researching for them, I would think. And if it was denied, is there an appeal process? It's a possibility.
But I would say depending on the individual hospice, they're gonna say either they have it available or they don't.
Yeah.
So there are, like, the things that I've said today, right? This is my perspective from VITAS. And there are others that may not have the resources or the ability to provide everything, but right, there are a lot of hospices out there with a lot of different what do I want to say, approaches.
Right.
What I'm saying, this is what hospice should be, and this is what I work for every day.
Yes.
Yeah, a small company, yeah, they may struggle with being able to get something like that.
Right. Okay. And Joanne, the answer to your question about can you provide this to other people? We record these sessions as a podcast, and so it will be available to you to share with others on the Caregiver Teleconnection website. And it's www.caregiverteleconnection.org. So yes, that is available to you and anyone else that you'd like to share it with. So thanks for asking that question. Well, we have gone over a little bit, and I'm so very pleased and happy that each one of you joined us today. Dr. Veeder, do you have any closing comments you'd like to make?
I just want to say thank you, all of you that joined, whether it's a specific person you're joining for or a multitude of people that you're joining for. I appreciate that there are other people who have this on their minds and are concerned about our people at the end of life. We need more of us out there. So thank you.
Thank you very much. And thank you all for joining us. Hope to see you on future calls. So look for the Caregiver Teleconnection calendar. We have a few more sessions left this month, and they're working on November. So thank you very much for joining us, and stay well. Bye-bye.
Thank you.
Bye.